Okay, I have the pleasure of presenting Dr. Gary Reisfeld. He is the assistant professor in the Division of Addiction Medicine, Pain Medicine, and Forensic Psychiatry in the Department of Psychiatry at the University of Florida College of Medicine in Gainesville, Florida. His major research interest is adherence, monitoring and long-term opioid therapy. He's authored numerous peer-reviewed articles on the topic. Please welcome Dr. Reisfeld.
I really think you should probably save that till after. You may want to take it back. Anyway, thank you for coming. As you know, you're probably most of you involved in opioid management. Drug testing has become a big thing. In some quarters, it's become standard of care or required. We're hearing more and more that immunoassay screening has very limited usefulness. We now have these very, very fancy high-tech methods of drug testing that are also very expensive. So I'm here to tell you that I think that immunoassay drug screening is here to stay for a while, but it's very important to understand what its strengths and its limitations are. So that's what we're going to talk about this morning. And this tends to be a provocative topic, so there's going to be a lot of built-in time at the end for questions, answers, and discussion. I don't claim to have all the answers, but maybe we can have a healthy discussion at the end. I have nothing to disclose. So from the very first time we started medical school or pharmacy school, we're told that the most important thing that we need to make a diagnosis is the patient history. We have to believe our patient. This is, most of the time, what enables us to make a diagnosis, patient history. So we have to believe what our patient's telling us. But on the other hand, we as Homo sapiens are, we're liars. And I'm not ashamed to say I've told several lies already this morning. There was a study that came out of UMass several years ago in which psychologists took dyads, groups of two people who didn't know one another, and they were to have a 10-minute conversation about anything. And so they had this 10-minute conversation. At the end, they sort of deconstructed these conversations, and it turns out that most of the people in these dyads told a lie. And most of the people who told one lie told more than one lie. So here we have a very low-stakes situation in which, there's no point in lying, but people do it anyway. My most important source of medical information, NPR, had a story not too long ago that said that more than half of college freshman males, most of what they told their mothers were lies. Yeah. So you can imagine then in a high-stakes situation in which your ability to construct a convincing narrative is the only thing between you and your opioids or benzos or amphetamines, that there may be more of a tendency to tell a mistruth. And so I'm just going to show you one study this morning. It's a study that's a few years old, but it's actually a very good study. And this was done by a group in Boston at one of the Harvard hospitals. And this is a retrospective study. They looked at about almost 500 patients who are on long-term opioid therapy. And when the patients came in for their monthly visit, they were asked to give a drug screen. And they were also asked what medications that they were taking, what illicits they were taking, what controls that they were getting from other physicians, and also what their pattern of use had been in the 1, 2, or 3 days before the test. And then they took these urines and they subjected them to a very sensitive and specific kind of testing called gas chromatography mass spec. At the time, the most sensitive and specific testing method that was available. And these were the results. 55% of the patients, 470 patients, had a normal expected drug test. Okay? 10% were missing the prescribed opioid. All right? So when they went back and asked them why there was no opioid in their urine, when they said they'd used it in the past 1 or 2 days, They said, well, they'd run out early. But of course, you know that when there's no opioid in the urine, it opens up a whole differential diagnosis of what may be going on. Well, maybe they didn't have pain yesterday or today, but maybe they're abusing, maybe they're addicted, maybe they're diverting. 14.5%, the orange slice, had an additional prescription medication in their urine that they did not declare at the time of the urine drug test. 17.6%, the green slice, had an illicit substance in their urine, most commonly cannabis. Second most common was cocaine. Third most common was heroin metabolite. And then the final slice, about 2.5%, had a specific gravity creatinine or pH that was not consistent with human urine. So the take-home point, and this is sort of representative of other studies that have been done like this, the take-home point is that in a tertiary care academic pain program, about half of the urines come back with expected results. So how then do we manage this tension between wanting and needing to believe our patients and knowing that they're not completely truthful with us? Any Russian speakers in the room? So most of you are old enough to at least identify the players here. So back in the 1980s when Reagan and Gorbachev were having their INF negotiations, in preparation for the meetings, Reagan was educated, briefed by a criminologist who said that the Russians really love proverbs. So you should learn a few proverbs, and you're a good actor, you should use them, sprinkle them around liberally in your talks with Gorby. And so at the final signing of the treaty, Reagan evoked this. It's actually a rhyming proverb in Russian. It's doverяй, no proverяй, which means trust but verify. And so at the final signing, Reagan again emphasized how important it was to both trust and verify with the Soviets. And Gorbachev said to Reagan, he said, Ron, every time we get together, you say that. And Reagan said, yeah, I like it. And I like it too. So for the commercial laboratories that are telling us to test more, to test often, to test large panels of drugs, it's sort of understandable because for drug testing laboratories, urine is the object of analysis. But for us, the patient is the subject of analysis. And so urine drug testing is only one piece in a larger puzzle that gives us the information that we need to effectively and safely manage opioids in our patients. And so these are the other pieces of the puzzle, patient behaviors. And you're all familiar with these behaviors in the office, for example. Grooming, which has changed. Affect, which has changed. Behaviors that occur outside the office. I lost my medication. They went down the sink. They went down the toilet. My dog ate them. They were stolen by my niece. Pill counts. I don't know how many of you use pill counts. We use it regularly in our clinic. Our practice, our sort of default mode in our clinic is to see patients every 28 days. So our Wednesday patients are Wednesday patients, our Friday patients are Friday patients. But we prescribe 30 days worth of medication because, kids get sick, tires get flat. You don't want your patient to ever run out of opioids. But this means that when they come to see me every month, they should have a couple of days worth of medication left in their bottles. Now, I can tell you, I've been practicing for a long time, I can tell you that in the history of medicine, no patient has ever run out early of their thyroxine or their labetalol or their oral contraceptive pills. They run out of opiates, they run out of benzos, they run out of stimulants. And so we ask the patients to bring their bottles with them every month, and sometimes we look at the contents and sometimes we don't. But by looking at the contents of the bottle, if they're a little short, we can sometimes intervene before a very small problem turns into a larger problem. Prescription drug monitoring programs. Everybody here, unless you're from Missouri, has one. Physical exam findings. Again, it comes back to sort of the grooming issue, the dress issue. Every once in a while, we actually find track marks, but you have to examine your patient to find those. And then collateral sources of information, and sometimes we'll speak to loved ones. There was a participant in one of the conferences I gave who said that part of his opioid contract was that he had to be allowed to speak to the patient's relatives about how they're doing in life. Because the fact of the matter is even if you see your patient once a month for 15 minutes, for 99.999% of the month, you don't know what's going on. So when we talk about drug screening, we're talking about immunoassays. When we talk about immunoassays, there's two flavors. There's the point of care and there's laboratory. It's actually not quite as neat as that division, but for the purposes of this discussion, there's going to be point of care, which is non-instrumented. So these things like cups and strips and cassettes versus laboratory-based instrumented immunoassays. Did I just do that? I'll talk a little bit about both. So the major distinctions between point of care non-instrumented immunoassay and a laboratory-based is that there are things called CLIA requirements. So CLIA is the Clinical Laboratory Improvements Amendments from 1988. And CLIA is administered in part by the FDA, in part by the CDC, and in part by CMS. And FDA classifies immunoassays in terms of their complexity. So there is low complexity, moderate complexity, and high complexity. Low complexity is called waived. So for laboratory-based, the CLIA requirements are that the people who are conducting the tests have to meet certain educational requirements. There are quality assurance and quality control stipulations, and there is thrice yearly proficiency testing. Also, these labs are subject to inspection. On the other hand, these wave tests, which comprise almost all of the cups, strips, and cassettes, are simply plug and play. You take them out of the box and you do the test, and that's the end of the story. Because of this quality control, the results from laboratory-based immunoassays are probably going to be more uniform than the point of care. Typically, but not always, there's going to be a wider selection of analytes. And when I say analytes, this is a shorthand term for a substance which is analyzed. So it may mean a drug, it may mean one or more metabolites. An important distinction is that a test that's done in the laboratory is going to be billable to the laboratory. A test that's done in your office will be billable to your office. And so this will enable you, it doesn't pay a lot, it pays about $20, but it enables you to offset the cost of the